do for a lot of active people. You hear about athletes all the time with this kind of injury, and so that's what we're going to talk about today. I am a sports medicine fellowship trained physician, and so this is one of the things that I specialize in as far as taking care of this kind of sports related injury. Obviously, it's not always sports related, but that's what we call it. So, so what is the ACL? The anterior cruciate ligament is one of the four main ligaments that are inside your knee that help keep the knee stable. And you can see on this drawing here, this schematic kind of drawing, but the ACL is deep in the center of the knee. It's one of the two cruciate ligaments, the other one being the posterior cruciate ligament. So you have the ACL here in the front and the PCL behind it. And these ligaments are way deep in the center of your knee. So you can't touch them or feel them. People think, well, if I tore my ACL, can I feel it or anything or touch it? You can't, because it's way down in the center. So the other two main ligaments are on the outside, closer to the outside of your knee. Those are the medial collateral ligament over here and the lateral collateral ligament over here. And these two washer things are the meniscus cartilages, the medial and lateral meniscus, which are like little washers of cartilage in your knee that people often injure those at the same time they injure their ACL, and often need surgical treatment for that as well. So, so how common are these? Well, pretty common, about 200,000 ACL ruptures per year in the United States. Whoops, sorry about that. And an incidence of that's about 1 in 3,000. Females do sustain this injury more commonly than males, and there's been a lot of speculation, a lot of studies, looking at why that is. We don't really know 100% for sure. So a lot of people think it has to do with the anatomy, such that women have a little more valgus, or a little more knock knee angle at their knee, and a little bit wider pelvis, and that alignment may predispose them more to these kinds of injuries. So most commonly we see them in folks who are about 15 to 45 years old, but they can be younger and they can be older. And obviously you hear about a lot of young and active athletic people getting these treated with surgery, but it's actually beneficial in older people too, to make their knee more stable and try to hopefully prevent them from getting arthritis in their knee, because the instability or looseness in the knee that goes with your ACL being torn can lead to tears in the cartilage and arthritis in the knee. So after, generally speaking, from after an injury like this in surgery, it takes about 6 to 8 months to get back to like a full activity level. You've probably heard of athletes who are out for the season and they really don't come back until, the next year as far as being competitive. So how do people injure the ACL? Well, there are two main ways. It's typically associated with a twisting kind of injury to the knee, and it can be either through contact, like you see, somebody playing football, somebody actually hitting their knee, striking, running into their knee as they twist it. But sometimes, as you see with the skier over here, just twisting the knee in a non-contact way, just having your weight on it and then twisting around it can tear it without anybody actually coming in contact with it. So again, this is just kind of what you see schematically. And as far as what you see on the inside, ACL tears can be either partial, like you see here, where just parts of the ACL is made up of thousands of little fibers, and here, some of those fibers are torn, but not all of them. And in those situations, those injuries can heal without surgery. although that is less common than what we typically see, which is a complete tear where basically all the fibers are torn, and that has led to the knee being unstable or loose as a result. Also sometimes, especially in younger people, rather than the ligament tearing through itself, it actually pulls off where it is attached to the bone, and a little piece of bone pulls off with it. We call that an avulsion fracture, and that can be repaired actually by reattaching that little piece of bone back down without having to put a whole new ACL. And again, like we talked about, the ACL injury comes from this knee being, knee being twisted. So you have the tibia, the leg bone, kind of twisting relative to the femur, and as it twists, that ligament just gets stretched to the point where it can't take it anymore, and it finally tears. So what do you see with somebody who's had an ACL? What are the signs and symptoms? So when we see people come in with ACL tears, a lot of times it's because of an acute injury. It can be either acute or chronic. So a lot of times it's because they've had a recent injury where what we described just now happened, and the history they give, they say, well, I twisted my knee and there was a big loud pop and it hurt. And then right after that, the knee started swelling up a lot and getting bigger. And the reason for that is that the ACL is very vascular. It has a lot of blood supply in it. So when that ligament on the inside of your knee tears, it starts bleeding inside. And so your knee will fill up with blood, and that's why it swells. And then they have difficulty bearing weight because it's painful and sore and swollen. Sometimes we see folks who have had a chronic tear, like they may have injured their knee years and years ago, or whenever, a long time ago, and they maybe never had anything, maybe they never went to the doctor, and they just kind of let things settle down and kind of went on. But they're like, well, my knee's never been the same. It just feels chronically loose. It kind of gives way. It doesn't feel stable or anything. So at that point, when you see them, their knee isn't swollen anymore necessarily, but they just have some chronic symptoms of giving way or instability, and often when that happens, the knee will get painful and swollen. They'll have incidents where that has happened. So how do we make the diagnosis? Well, of course, the history is a big part of that. That history is very typical for an acute tear, is feeling the pop and then the immediate swelling afterwards. That's a classic history. On physical exam, again, when it's acutely occurred, we'll see a lot of swelling in the knee. Some tenderness perhaps, but maybe not, because like I said, that ligament is way down inside. So sometimes they get some tenderness because there's also, when the ACL tears, the bones kind of bang into each other and bruise each other, and they get some bone bruising, and that can make the knee tender a lot of times on the outside of it. So they'll typically be swollen. They'll have limited motion. In other words, they won't be able to fully straighten their knee or fully bend their knee. So those are the typical things we see on exam. And as far as what we do in the office, we get x-rays, and usually that's not going to show anything. Usually there's not going to be any broken bones, but we just want to make sure, obviously, so that's where we start. And then the diagnostic study that we end up having to get pretty much on everybody who's had this injury to confirm it, or really confirm that diagnosis, is an MRI, which will actually show us all the soft tissue structures in the knee. So it'll show the tendons, ligaments, cartilage, etc. So we can tell for sure when the ACL is torn on that. It's really good for seeing that, but it will also tell us about the meniscus cartilages in the knee, whether they're torn, those things I mentioned earlier. And it'll also tell other things about, the joint cartilage itself, the cushioning cartilage, and what kind of shape that's in, as well as the other ligaments in the knee. So sometimes people do tear more than one ligament at a time, like they can tear their ACL and their MCL, or ACL and the PCL. Sometimes that's a rare injury, but so they can get a multi-ligament injury as well. So acutely, what do we do for that? We see somebody who's just done this. Well, of course, we do the typical things like rest, ice, elevation, and compression. and all this is aimed at, getting the swelling down, making the patient less painful, more comfortable. We often will put a brace on for support, and use crutches to help them get around. Usually you can put some weight on it, and especially as the swelling and soreness goes down, people can start to put more weight on it, and they start to work on getting their range of motion back. So which patients do need surgery for this versus not having surgery? Well, most people do. Most people would benefit from surgery for an ACL tear. I mean, obviously, if somebody's really elderly or inactive, they may not need it. But most patients who are active and not necessarily in sports, but just in day-to-day things, but even may enjoy just walking or getting around, et cetera, or doing things around the house. Because, even those patients often will have feelings of instability or looseness when they're doing things if their ACL is never fixed. And so most people will benefit from that. Patients, of course, who have other injuries in the knee, like a torn meniscus that has, if a piece of that is flipped out, that's going to be causing pain in the knee. And those people obviously are going to definitely need surgery. And that can be done at the same time as the ACL tear. But even like I say, if that's an isolated injury in a young, especially in a young person, and they've not done anything but tear their ACL, it's going to be a good idea to fix that, because it's going to it'll make their knee more stable, and then hopefully prevent them from having more trouble in the future as far as episodes of the knee giving way and causing further injury to the cartilage and ligament and other structures. So what kind of activities do you really use your ACL for? So here on the left, we see ACL dependent activities. In other words, these are activities that you really need your ACL to do. If you don't have one, you're going to have a hard time doing that. And that pretty much involves anything with cutting activities where you're planting the knee or planting your foot and then, changing direction. So like basketball, soccer, football, softball, tennis, cheerleading, skiing, all these activities really depend on your ACL. High-end aerobics, skateboarding, hiking on difficult terrain, a lot of laboring jobs, basically any activity where your knee buckles and gives way, when you're doing it. Things that you really don't need an ACL tip, strictly for are just basically things where you're walking in a straight line or jogging in a straight line, if you have a desk job or riding a bicycle. These things don't really technically require an ACL because the knee isn't really twisting in those types of activities. So if you don't, like I said, if you don't get it fixed, what do you do? What happens if you don't get your ACL fixed? You're going to have that looseness or instability in your knee. And every time that knee gives out, I mean, there are people who get by with a torn ACL and they don't seem to have a lot of trouble, but those people are more the exception than the rule. Most people, they're going to continue to have episodes of giving way or instability. And every time that happens, they run the risk of doing an injury to other structures in the knee. And then what happens if those things get hurt, like if the meniscus tears, then it puts more stress on the other cartilage in their knee, and they're at risk for getting a lot more arthritis in the knee. That's the one thing, that's what you really want to prevent going forward down the road. So what do we do? What do we have to do beforehand? What are the preoperative requirements for ACL reconstruction? The main thing is getting the range of motion back. At first, like I say, when people have torn their ACL, they aren't able to move their knee fully because it's swollen and it hurts too much. And sometimes if people have done surgery before people got the range of motion back, they have an even harder time getting it back after surgery. And sometimes they end up with stiffness in their knee, or we call arthrofibrosis, which is a real bad problem and can be hard to get rid of. So we don't want that to happen. So before surgery, it's good to have all your range of motion back, which most people don't have too much trouble getting, in a couple of weeks time or so after their injury. Physical therapy can help do that if people are struggling with that. So So when it comes to repairing or reconstructing actually your ACL, we use different grafts. Basically, we can't just go in there and sew it back together. People tried that initially a long time ago, but never found that it never worked because it just wouldn't heal well. So what the operation evolved into was basically reconstructing the ACL with a graft. So taking a piece of tendon basically from somewhere else and putting it in the knee and making a new ACL out of it. So when we do that, we can either take tissue from yourself, the patient, and that's called autografts, and typically comes in the form of either a patellar tendon, which is the tendon in the front of your knee, or a hamstring. I like using the patellar tendon because you can take a piece of it from your front of the knee, and on each end of it, you get a piece of bone. There's a little piece of bone from the kneecap and a little piece of bone from the shin bone on the other end. So you have this bone, patellar tendon bone. So it's got a nice piece of bone on either end, which you can attach to the, when you're hooking it in and attaching it. It's nice to have that bone on either end because you use this little screw to fix to it, and it does well with that. Whereas a hamstring autograft is all soft tissue. It's all tendon. There's no bone, and you can still fix it well. And a lot of people like that, but I like the patellar tendon, and that's been sort of the gold standard, for a long time. All the NFL players, et cetera, that's generally what they're using. So those are the main autograft options. You can also use donor tendons, which come from a cadaver. And there are advantages to using that, because, and again, we use patellar tendons a lot, from donors as well. The advantage being that it's much less painful because we don't have to cut that graft out of the patient. From surgery, from using an autograft, that's usually the most painful part of the procedure, is actually where you took the graft from. So if you eliminate that part of the surgery and you're taking the graft from somewhere else and putting it in, there's a lot less pain after surgery. So the recovery is a lot kind of quicker and easy. I mean, it still takes the same amount of time for the graft to fully incorporate, but the initial recovery time is much easier, much less painful. And the incisions are smaller. We don't have to make as big an incision. It's good for revisions too, where somebody's had an autograft, before, and they retour it again, you have to redo it. Well, you definitely, because obviously you only have so much tendon tissue to use on yourself. It's nice to have the allografts available. The studies have showed very good results with these. Some studies have showed that, or have suggested that maybe they're not quite as tight when they turn out, as an autograft, but they still are very effective. And so a lot of times when very young people, we favor the autografts, teenagers, maybe 20 somethings. And then as we maybe get a little bit older and a little bit less active, the allograft becomes a better choice. There is theoretically a small risk of disease transmission from the donor, but these, I've never had that happen ever. This tissue is always screened thoroughly. It's run by tissue banks, which are accredited and inspected, et cetera. So the chances of that happening are very small. So most of the surgery is done with a scope, where we do it through little tiny incisions with a camera inside the knee, or scope. And this is just a picture, a typical scope picture of what you see when you look inside the knee of a normal ACL. So the femur is up here, the tibia is down here, and this big thing right here is the ACL in all of its fibers. And this one is intact, it's not torn. So when we do have to reconstruct one, and we see, that it's torn, et cetera, we take out what's left of it, little scar tissue that's there, and we clean that up, and we basically make little tunnels or holes in the bone where we're going to pass our graft through so we can fixate it. So we make this is the femur we're looking at, and inside the knee, we make a hole over here, or tunnel. We drill this tunnel. And that's where one end of the graft is going to go into that hole, and it's going to be wedged in there with a little screw that's going to hold it in. And on the other side down here, there'll be another tunnel through the tibia in the other end. So it'll go through this tunnel and then across the knee joint and then into this femur up here, and it'll be fixed on both ends with a screw. So again, here's a picture of after that's been done. So again, your femur's up here. That's your femoral tunnel. The graft is up in there. There's bone on that end, and then tendon. And then on the other end, in that other tunnel, is that other piece of bone. And then so there's a screw up in there and a screw in there that are wedged into the tunnel to hold it in place. So these screws I mentioned, this is kind of what they look like. They're called interference screws because they basically just wedge in there and kind of, hold it into that tunnel. And you can use either absorbable ones, which are these kind up here that kind of look like plastic. And over time, your body will reabsorb those, or you can use good old fashioned metal ones, which don't absorb. And they're buried inside the bone. You can't see them or anything except on an x-ray. A lot of people say, well, they set off a metal detector. No, they typically don't, because there's not that much iron in them, and they're small. So post-operatively, what do we do? Well, the surgery is done as outpatient. You go home the same day. You have crutches and a brace. You start your therapy right away to get the knee moving. You work with the physical therapist to do that and work on getting your range of motion and strength back. And you're putting weight on it and gradually increasing the weight. And as your strength improves and you get, enough strength in your leg back that you can walk without limping, you can do away with the crutches, which is typically somewhere between 2 and 4 weeks. And then you're kind of just walking around normally and continuing to work on your motion and strength. Usually you can get back to running or jogging in a straight line or on a treadmill at about 3 months. And then as far as getting back into full, like cutting and twisting activities, is in at least 4 months. But like I said, it's usually at least 6 months and often a year, up to a year, before people will, be as good as they will be. So it does take a while. Man, that's mostly getting their strength back. It takes a while. Because the quadriceps lose a lot of strength after this injury, and it takes a lot longer to build them back up than it did for the strength to go away in the first place. So, and that's about all I got. Thanks for listening, and I'll be happy to take any questions you might have.
Thank you, Dr. Reynolds.